introduce the guest for today. She is Akashi Vyas. She is a certified genetic counselor with a specialization in biomedical genetics from VIT. And she has extensive experience in reproductive health, including prenatal and preconception counseling. And she is very passionate about bridging the gap between complex genetic information and the real world implications, and of course empowering individuals and families through informed decision making in genetics. So over to you.
Okay, am I audible?
Yes, you are.
Thank you so much for such a warm introduction, Sukriti. And hi, everyone. Good evening. And it's really wonderful to see you all, to see such a enthusiastic group of people. And I am really grateful and excited to share this session today because today, what we'll be talking about is not just genetics or testing, but we'll be addressing the gap between what people think about genetic counseling, what actually happens in the process, and how we move from raw data to meaningful decisions. So, as Sukriti said, my main field of interest and work is in reproductive health and rare disorders. And over past few years, I have worked closely with clinicians of different specialties and many couples who are navigating fertility, pregnancy, and genetic risks. And with all these, I have learned one thing, and that is counseling is something where science and emotions meet. It's where clarity replaces fear and where options become pathways. So, today, instead of sticking to all the textbook definitions, I will try my best to walk you through what really a session looks like, how typically it unfolds the details using real case scenarios, and demonstrate the impact of genetic counseling and its value beyond reports. Before jumping to the scenarios, let's just briefly align what genetic counseling truly means. And trust me, it's not just suggesting tests. It is actually a structured and layered process of understanding, communicating, and empowering complex genetic information into meaningful guidance. So, in general, when we look into the healthcare system, clinicians are already so much occupied with the patient load and the procedures and the various other clinical decisions of their own field. So, their role is to diagnose and treat. And so, one genetic counselors or geneticists bring time, interpretive skills, and communication space that couples and families desperately need. So basically, we empathize with evidence. That's how I come to the conclusion when I look into the genetic counseling perspective. Uh, I'm so sorry. I would have to turn my camera off for a while because there's some
You're able to
technical.
share the screen, no option है ना?
Ha, sharing screen का option है. I'll share that in a while.
हाँ
So
ठीक है, okay, no worries.
yeah, so as I am more specialized into reproductive counseling and preconception counseling, today we'll keep our conversation mainly around the reproductive health, where the couples are often anxious or overwhelmed or confused. And firstly, we'll look how a typically sessions flow is like. It's not a rigid flow, but it's a instinctively structured flow. So whenever a patient comes for a counseling or a clinician has referred them for counseling, the first instinctive response would be rapport building, right? So when I prepare myself for a counseling session, the first thing I have to look forward to is rapport building with the patient. So where we allow them to talk first, like we greet them and we start the session, but we don't upfront ask what is the reason for counseling, or do you know what you are going to do here, how we are going to decide everything. We allow the couple to talk, And we just basically ask them, do they have any idea for why they have been referred for counseling, or do they have any um, brief information about what this session is going to be about. So this will just basically set the tone for the entire session, and you will also get a basic idea like how much the patient is prepared, or how much knowledge they have about the genetic counseling or whatever they are referred for. Then it is followed by information gathering. So here we take detailed family history, medical history. In case of reproductive health, we also look into the obstetric history and the menstrual history and everything for the female and male as well. So this part usually allows you to explore the entire family history, and in some cases, it will reveal the hidden patterns within the individual and in the family as well. So this will allow you to this will allow the patient to trust you, as well as when you take the pedigree, there will be many a times, there will be instances when initially when they start talking to you, they won't tell you anything. But once you start taking the pedigree, they see that you are drawing that square and circles and all the signs. So that is the time when they'll realize that, okay, if she's writing or he's writing something on the paper, that means it is important. And they will start sharing information and they'll start trusting you more. So drawing that pedigree in front of them, like making them understand also, is one important step I have realized so far. So that will really like unfold the stories they are not comfortable to tell you or tell anyone, in fact. Majorly the clinicians, they are not comfortable to share all those information to the clinicians. And we'll see in the case scenarios as well, if there are any cases where when while collecting the family history, we get to know that, okay, mother was affected and father had this issue and the siblings had this issue. So this is also one important part where you gather the information in such a way that they want to share more information with you. Then comes the risk interpretation part, where you don't tell them what are the test results. You explain them what are the test results. You explain them what that numbers and what the findings they have got, what they mean. So like when someone is coming to you with the reports, let's take example of double marker report, or any pregnant female is coming to you with telling that I have a risk of 1 in 100 for Down syndrome. So 1 in 100 risk of Down syndrome, they are aware about what that means, but they are not able to process that emotionally. Right. So in that case, you have to like your counseling session or the information that you're delivering should be in such a way that they can emotionally process that, or they can accept what the results are. They know 1 in 100 risk is what is 1 in 100 risk. But you need to deliver that information in such a way that they are able to accept that and they are able to understand that. Before that, sometimes the option of explaining the testing options also do come in scenario while taking the session, which includes them giving them detailed information about benefits of the test, limitations of the test, accuracy and possible outcomes of the test. So when you are involved in reproductive counseling or preconception counseling, one of the main point that is to be focused in explaining them the possible outcomes, right? Because uh, prenatal cases are such cases where there's an ongoing pregnancy, so they are already worried about what will be the test results and what will happen if something comes out. So making them prepared that these are the following outcomes that you can explain. Suppose if anyone is undergoing NIPT, so NIPT is a screening test, so the possible outcomes would be different in that case. If someone is going for carrier screening, the possible outcomes are going to be different. So, based on your case scenarios, the possible outcomes, telling the patient or the couple the possible outcomes of the test is really very important in reproductive settings. Right. Then one part comes, and this is also one of the important part, and that is decision support. So when it comes to taking the decision, it's always the couples who decide. We as a counselors don't influence any decisions, but we do empower them. We guide them with what is the right option for testing, but we don't push them or we don't force them to take that decision. Like if karyotyping is needed in a couple, we don't force them that this is a mandatory test for you, but we do guide them why it is important to take this test, right? Otherwise, in any scenario, if even if it is a prenatal testing or preconception testing, even if it is a positive family history case, decision is never supposed to be taken by a counselor. They are always supposed to empower or even empathize the decisions to be taken, but not influence the decisions. So this is also one important thing in a counseling session, and the steps that is generally followed. And some like we need to conclude the sessions as well. So me generally, I conclude the sessions where I summarize the points to the couple what we have discussed in the entire session, to make, and I also make sure that their questions are addressed properly. Like they have very common questions sometimes. Like the most common, if they have family history, positive family history, the most common question would be, would they pass on the same thing to their next generation? So when the testing is not done, you are not able to define that. So navigating the same information to them, making them understand that all is part of the process, but you don't have forever to complete all the sessions. So you have to make sure how you're concluding the sessions as well. And it involves quickly summarizing the points to the couple or the family and making them understand these are the testing options. You also make sure that the questions which they have asked are addressed properly. Again, there also you need to keep in mind that you don't have to push them too much to take any decisions on their behalf, or even you're not supposed to push them to take decisions which you have made in your mind. Because when you're counseling someone, you are very much aware about the science behind it, the right decision to take, but you cannot, you have to be neutral. You don't have to show that okay, this is very much important for you to take the test, or this is not at all required. All these things as a counselor you have to be very neutral in that case. And uh, when there's an in-person counseling, we do give some handouts as well, so that they can refer the same when they are not in the session, not part of the session, and they can rethink the entire session looking into the basic points they have on the handouts they have. And I also, like, we as a genetic counselors also ensure that they know what to expect if they are undertaking any test which is suggested to them. And in few cases you might also need to follow up, you, when you start counseling the patient or the couple, you know the couple is very anxious or couple is panicked, or they have information which is not needed but still it is there in their mind. So sometimes you give them some space, you give them time to process the uh, things you have explained to them, and then they might need a follow up. Because even if we go to the clinician, sometimes doctors, sometimes they give us some of the other suggestions, but we don't follow up with them. Even if they have asked us to follow up, we don't go and tell them that okay, this is what I'm thinking. So sometimes we do need to take a follow up with the patients as well, if they, to just see if they are able to make up their mind or not, and if they require any extra suggestions or any extra support. So, okay, this was like a little bit of briefing about how genetic counseling sessions are and what are the steps that are generally followed. Those are not rigid steps, but not every time you have all the information beforehand. Sometimes there are sessions which are very spontaneous and coming, like walk-in patients coming to you, and you don't have any file or any idea about the patient or the clinician or anyone. So in those cases you have to follow your instincts. You have to not instincts as such, but you have to look into the data accordingly. You don't have time to research everything and what test you'll be able to suggest and everything. The straightforward cases are easy, but if it involves some rare disorder in the family, you might need some time. So we'll see all those things when we see the case scenarios. So let me come, let me share my screen, and I will show you one pedigree. Is it visible?
Yes.
Okay, so in this case, I have not entirely mentioned the case scenario, but I made a brief pedigree. And in this case, there's a couple in their late 30s who already have one 4 year old daughter. She's healthy. And after that, they have been planning for the pregnancy for a very long period of time, but have faced three spontaneous abortions and 5 times failed IUI cycles. Physiologically, everything is normal. The hormonal levels in female are normal. The USG for uterus is normal. Her like husband's semen analysis was done, that was normal, and hormonal testing were also done, that was also normal. So here the clinicians are not able to decide what is the issue. The family, there's no significant family history. They are not able to decide what is the problem here, why everything is normal, still they are not able to conceive. So anyone would like to share, like, how will this, what do you assume with the factors, or how will you guide the patients ahead, like the couple ahead?
Like any one person out of them can be carrier for balanced translocation, so it would be better to go for couple karyotype.
Okay, that is the great, like that is the only choice of testing in first line of testing. But anything else you would like to, like, take information about? I said physiologically everything was normal, but hormonally everything was normal. Do you ask any other questions in this cases, in such cases?
If they've had any risk to some kind of um, some substances which could be affecting pregnancies, maybe.
Okay, so in this case, the thing was, we asked her blood group. So her blood group was B negative. So somehow she had been explained, or the family was explained, that because of negative blood group, this was occurring. The spontaneous abortions were occurring because the fetus's blood group was opposite to the mother's blood group. So what do you do next when you get this information? If the couple is sharing this information, what would be your response? Anyone would like to? Okay, so when a mother is having a negative blood group and she conceives, the first pregnancy is not at risk. Okay, but from the second pregnancy, the fetus is always at risk. Like it sometimes lead to spontaneous abortions, or may lead to some of the other conditions as well, because the Rh negative factor will act as an antibody for the mother's blood.
Hmm.
So in that case, anti-D injections are given to the female after every pregnancy. And the Coombs test is a kind of test which will look into the antigens in the mother's blood for the antibody of the um, blood of the fetus, and it will test whether the blood is okay to tolerate the pregnancy or not. So this was the question that was asked next, and they did tell that okay, anti-D injections have been given after each and every pregnancy, even after the three spontaneous abortions, and Coombs test also was normal. So then, when the couple had come in for counseling, the someone said, I don't know who, but someone said that karyotyping is the one test which would be suggested here. So we suggested karyotyping to them, and the husband came out to be the carrier for a balanced translocation. Okay, so here then the balanced translocation. What is balanced translocation was explained to the couple. Sometimes couple will understand what scientific language means. but sometimes they don't understand what does chromosomes mean, what does genes mean. So I generally prefer, I am from Gujarat, so majorly patients who are coming to me are Gujarati. So I did start one practice, and that was, people have some or the other time learned science in their schooling system or anyway. So I learned um, uh, the native language words for genes and DNA and everything, which made the counseling sessions a little easier to make them understand what those concepts are. So then, with that drawing and the native language words, I was able to make them understand. Okay, this is chromosomes. These are genes, and this is how it works, and this is how balanced translocations are. And this might be the reason for your spontaneous abortions and 5 times IUI failures. So then PGT was suggested to them and everything, and then they had a very successful and healthy pregnancy. And but there was one thing for this session that was always concerning to me, and that was, um, because earlier it was explained that negative blood group is something that is causing this. The female was kind of considering herself responsible for this to happen again and again. And with her response, sometimes when the actual session is going was going on, it did feel like, the husband was also, he was not saying it open out, but somewhere he was also believing the reason for the same, because he was also not aware about the genetic perspective. So yeah, so then in such case scenarios, what you can do is you need to learn the emotions of both the partners, and you have to be neutral enough to not show your reaction to that. Okay, sometimes we might get angry that we, because we know that, okay, this is the highest possibility is there's a balanced translocation in neither of the partner, but we are not supposed to show that reaction to either of them, like, okay, what the husband is thinking is wrong and the what wife is thinking is wrong. Instead of that, you are supposed, like, as a counselor, you need to understand the emotions from where that perspective is coming, and you need to address that as well. So in such case scenarios, you can always ask the wife in a neutral way if she wants to talk about anything else, if she is more comfortable to talk alone in the session, and whatever, however she is comfortable. So in this case, we did talk to the wife alone, and she was able to share all the social pressure and the assumptions she had been making for a while. But then, when the results were explained to both the couple, they both were like on the same page, and I realized that there is one entire hidden cause for this. So this case did highlight that. Genetic counseling becomes the bridge between failed clinical outcomes and to recognize the hidden genetic causes. And when the genetic perspective was looked upon, things changed in this case, and a new pathway was opened for them, which led to a successful pregnancy. Okay. Anyone else wants to share any other perspective to this case, or anything like what would have happened if this was not the case scenario, or anything like that? Anything someone wants to add to this?
Like I had similar experience with one of the case, and in that case the women perspective was whether it can change over time, like with nutrition or anything. So I think we also need to address this thing beforehand, that this is something that doesn't change over time.
Yes, exactly. That's one of the common questions couple do have all the time.
Yes.
Like, do we have any medications for this
Hmm.
to change
Hmm.
the chromosomes and our structure,
Hmm.
or
Hmm.
do we have any Ayurvedic medicines for this or
Hmm.
not? So yeah, addressing that question is also very important. But you, not every time. I don't every time make them understand in such a way, but yeah, making sure that they know that these changes don't change with any medications, and they are there since birth, or that is one important point you need to make them understand as well.
Hmm.
And based on what translocation, like translocation between the chromosome is, Usually, you need to study the consequences of that and the risk estimation, whether it will be passed on. Here, clinician were not able to look into the genetic perspective was one, because usually in cases of balanced translocation carriers, what happens is from the starting of the pregnancy, they are not able to conceive. The pregnancy leads to spontaneous abortions within 3 months. So if the first pregnancy has led to spontaneous abortion, and the second and then third, that there are consecutive three, they do suspect some genetic abnormalities or some genetic changes in the couple. But here they were not able to suspect that because there was already one child who was healthy. So that was also one question that couple asked, that we already have one child who is healthy. So why did this happen afterwards? So explaining them the risk of recurrence and inheritance is also very important. Like making them understand that the risk estimation again depends on what kind of translocation it is, and based on the clinical indications they have showed so far. Okay, so let's see the next case. Okay, so in this case, there's a 36 years old female who has spontaneously conceived, and the pregnancy is about 14 weeks, between 11 to 14 weeks, and her USG is normal. And she came in the session very anxious and convinced that something was wrong with her pregnancy and it is not going to go well, because the combined screening of her USG and biochemical markers showed increased risk for Down syndrome. Okay, so anyone would like to tell me how would this counseling session go?
Like, it should be emphasized on that it's just a risk factor and it's not confirmation that the fetus is affected with Down syndrome, because this is most likely, like, mostly the this is their concern that their fetus is affected, and therefore sometimes what happens that they directly terminate the fetus. So primarily this should be emphasized on that it is just a risk, that high risk, or like that. It's not confirmation.
Correct, correct. It's very nicely put forward. So, yeah, you're right. So, here the main important thing is to emphasize on the testing methods that have been used. Not only the risk that is shown in the testing, but the methods that are used. Also, her one point that was supposed to be emphasized in this case was also the advanced maternal age. So the biochemical markers and the ultrasonography is gonna calculate the numerical risk. So explaining that numerical risk is also important, that the risk calculation is based on your ultrasonography marker, your hormonal levels, as well as your age. So here she was explained about the numerical risk. She was explained about difference between the screening methods and the diagnostic methods, and the normal ultrasound findings were also emphasized, and right choices of tests were explained to her, because she was very anxious. She was convinced that something was wrong. She was also worried about, because um, this was her first pregnancy, and no matter which pregnancy, it is very precious to any couple. If even if it is third pregnancy or fourth pregnancy, it is precious to any of the couple. But since she was falling into advanced maternal age also, she was a little worried about, and based on the results, she was more worried that something is wrong. So the right choice of tests were also given to her, explained to her. One was NIPT, and the other was diagnostic test, like going for prenatal testing options. But again, given her USG was normal, her hormonal levels were normal. She was more emphasized, or she was empowered, or she was guided to opt for NIPT mode, because and USG appointments, like USG what to be done time to time based on what clinician guidance is. And she did opt for NIPT and followed her USG appointments timely, and which led to a successful and healthy child. So, in this case, also, the half information that was provided from here and there led to the unwanted stress in her. Like, somewhere in the report, she found it that it is 1 in 100 or high risk for Down syndrome. So no one explained that report, right? No one was there to explain, but the genetic counseling session did explain her what does the report means. So here it means that she just did not need to explain the science, but she needed some understanding as well. And the need for going for screening test rather than diagnostic test was also explained to her. The clarity made her fearless and allowed her to take one informed decision, which led to a good outcome. Anything, any other perspective anyone would like to add over here? Okay. So, so what do you realize with what genetic counseling should be, like how they are supposed to be?
Anyone can pitch in. The discussion is open to everyone.
So there are multiple cases. There can be different scenarios. There can be here. I did take very few simple case scenarios which generally come into the system, but there can be more complex sessions as well. But when we see genetic counseling perspective in general, it is a calm, structural, and deeply patient centric sessions. Like, so they involve too much of, like, lot of listening. They involve simplifying science in such a language that they understand, and it also involves addressing their emotional reactions to this. It also involves supporting the ethical decision making, and you ensure that the family or couple genuinely understands their choices. You are not forcing them. And yeah, so when I look into the genetic counseling, I really am grateful for this profession. And genetic counseling isn't about predicting destiny, but it's about guiding the possibilities. So a good genetic counseling sessions do prevent unnecessary testing and guides for appropriate testing, which will lead to better clinical outcomes. And most importantly, it reduces the patient anxiety and fear, allowing them to make informed decisions. So yeah, I would like to conclude saying that each case when which we come across does teach us something new, and every family reminds us why this field is so meaningful. And yeah, I'm happy to take questions or thoughts, or even if anyone is interested to do some small basic mock session, I am up for it. Or in case I have one more scenario, if anyone wants to take that up.
We can do another scenario if there are no questions from anyone. Otherwise, the session is now open for discussion. That is how it usually goes. So, if there's any thoughts, any opinions, any personal experiences that you've had as genetic counselors in these specific scenarios, or any psychosocial aspects that you've specifically come across in prenatal situations, please do talk about it if you want to.
There was one more interesting case which I had. That was the first case which I had felt that made me very feel very happy. So there was a couple who were not planning for any pregnancy, but they came in to the hospital saying that there's a pregnancy. We don't want the pregnancy, but
Hmm.
somehow when the counseling session was done, it came out that they had a child who was previously affected with Joubert syndrome, but the child was clinically diagnosed with the same. There was no molecular diagnosis of this disorder,
Hmm.
and the child died. And within a year, they conceived again. So they were not willing to keep that baby. They were very adamant to go for the abortion because they had already faced one kid who was abnormal, and they did not want to go for the entire experience again. So that was my first counseling, and which I was doing independently. And somehow I made them understand about, I asked for the MRI reports and all the other reports. I asked if they are consanguineously married or not and everything. And somehow I did convince them to go for carrier screening. And they did go for the same, and they were found out to be carriers for Joubert syndrome. Both the partners were found out to be carriers for Joubert syndrome. And then we asked them, like, if they are willing to continue the pregnancy, there is this option for testing the fetus via amniocentesis, and we can check if the baby is affected or not. And they did agree for prenatal testing as well, and we found out that the baby was normal. And they then delivered a very sweet, cute little girl. And we are still, I did follow up, and till date, like after a few months or some time, they do make sure that they're following up and telling me that the baby is doing good and how old she is and everything. So those all counseling sessions do make you also happy that okay, you were able to guide someone in right way, which led to a very good outcomes. So yeah, that was one that case stays with me every time. I sometimes, as a counselors, we do sometimes get upset about counseling and everything. So that cases, some few cases remain like close to us, which helps us to like move forward with the profession we are in. So, any such experience anyone also else has, and if they would
That
like to
was a
say.
very nice experience, though. That was a very nice case. I'm glad you got to have that.
So there are multiple, but that was my first case, so that stays very close to me.
Hi everyone, good evening. Nibbi here.
Good evening, ma'am.
Hi Akashi, good evening. Thanks for sharing the cases and your experiences. So I'm just curious about like the practice, right? So do you, in your practice, tend to see a lot more cases post the diagnostic test, like once the results are there, or is it do you get referred pre-procedure for pre-procedure counseling, like before a CVS or an amnio is done?
Both the cases, I do get both, because few, like I'm still working with a fetal medicine expert. So he does send for both scenarios. But yeah, I majority of time I do get for pre-test counselings more. Post-test, because clinicians do understand what the result is, or maybe they contact the laboratory. So post-test counselings are not in great numbers. But yeah, few patients who want to learn the options and everything, they do come in for post-test as well.
Your patients are so lucky. And as a genetic counselor, I would say like you're so lucky to actually get to see patients pre-procedure, because a lot of the times when I get referrals is when there is a complex test report, whether it like sometimes NIPT or diagnostic test reports that are complex to interpret. That's not straightforward. That is when they think of a genetic counselor. So like your
Yes.
patients are like really lucky.
Yes, that is true. Like that was the case initially when I joined the field. There were cases, scenarios like that, that they used to come with the report. Or sometimes even the procedure of amnio is done, CVS is done, it has been sent to the laboratory, but the test is not decided. So that was the case scenario before, which was very like awful to see. But somehow then, with few clinicians which I have been in touch with, they make sure that I'm counseling the patient before, and then they are going for the correct testings.
Okay.
So those are basically from the area where I live in Gujarat. So
Okay. Okay. Yeah, like I practice in Bangalore, so perhaps the referral system and like the entire genetic counseling, genetic testing pathway is different, perhaps.
yes.
Um, yeah, I mean, standard prenatal genetic counseling sessions where there's some increased risk or soft markers seen on scan, those, and then subsequently people going in for diagnostic tests, either CVS or amnio centers, is very straightforward. I have had a few cases in like spanning my career. I think about 4 or 5 cases where after the pre-procedure genetic counseling, so they came with either like an absent nasal bone or an echogenic intracardiac focus. And so they had planned for CV as the consent form, and like all of that is filled. And then they come in, they have this conversation, and then the couple actually decide not to proceed with an invasive confirmatory test. Um, Reason being, so in my prenatal genetic counseling, these sessions, I also talk to them about what would it mean to you if, say, we do the diagnostic test and it came back as positive and that the child in fact would have Down syndrome. What would that mean for you as a family, etc., and exploring those scenarios. And then when we go through having that conversation, taking them through what the symptoms of Down syndrome might be, and some couples even have requested if they could speak to another parent who has a child with Down syndrome, and then they've decided to go ahead with the pregnancy. And turns out like the child is born healthy and well without Down syndrome, and this the risk was like 1 in 50, less than like 1 in 100. So that, or like other situations where there is, it's not for trisomies, but there are multiple findings like a cardiac anomaly that's picked up. And while they had thought about doing an invasive test and then terminating if there's a problem, etc., these are repairable conditions. So I did refer them onto a pediatric cardiologist, for example, to have a conversation around what would repairing this defect mean, and recovery, and like the prognosis for the child. And the couple, after having these different conversations, come back and then say, okay, it's okay, this is repairable, I'm not worried about the other stuff. And they've gone ahead and decided not to do the prenatal diagnosis, which obviously the rest of the team is not like very thrilled about. But like, I don't know, luckily or whatever, of course, the couple were confident in their decision, were confident that they've made an informed choice that fits well for them. But and like even me as a genetic counselor, when they've gone away from the idea of genetic testing, I've also felt nervous that, oh my God, what if the child is born and then the child has some genetic syndrome which they've not tested for? So yeah, I've had those experiences as well, and just wanted to share that with you.
Yes, multiple times it does happen that they have high risk NIPT, and they somehow are convinced that the pregnancy is high risk, and they directly terminate it. Directly, like they don't even, and then they come asking that if the next pregnancy is at risk or not. So that is also where the system or the referral system or whatever we say does lack the basic information about screening test and diagnostic test. That is also one frequent scenarios we have seen. Plus you did tell about informed decisions. I think that is also one difference, like here and people out in Bangalore, they are more understanding. Here, sometimes when we look into so many patients, we do understand that they don't take decisions after thinking about it or learning about it. They do take decisions based on what clinician is telling them or what the society is telling them or what they have experienced in past. They don't. That's what I said. Like they don't understand the science and they don't understand what are the outcomes. They just want to have everything to be normal. So but they're not ready to take risk or they're not ready to understand the consequences of whatever the testing results are. So I think that is also one point we do need to like navigate it again and again to even clinicians as well as to the patients. But in current scenarios, I think clinicians need to understand more importance of genetic counseling rather than patient understanding it. Sometimes I do feel that clinicians need a better understanding of genetics and counseling sessions rather than expecting the same from the patient and the people who don't understand science. It is not right to expect that they understand science. That the mediators are clinicians ultimately. So yeah, so that is one fact that has been lying around. So I don't know how many of them think the same, but that's what I have been thinking for a very long period of time now.
Yeah, I think like NIPT is one of the most abused tests currently that's available in the market. Like, regardless of whatever the history is, or whether they have a three-generation family medical history or not, bhejo for like NIPT, and that should give us the answers.
Yes, and they're expecting NIPT to give idea about different disorders as well. They're not understanding it is just for 23 chromosomes, pair of chromosomes, the entire structure. They want all the information from NIPT.
Yeah, yeah. I mean, I've had a family where they were asked to do an NIPT, and this is a few years ago, like when NIPT had just gotten into the market in India. So this is a couple who were based out of London, but had family in Bangalore, and they were visiting Bangalore, ongoing pregnancy. So they decided to meet. I don't remember whether it was a fetal med or gynec, and they just said, there is a family history of schizophrenia on the husband side of the family. And straight away, an NIPT was done, and the NIPT result came out suspecting Klinefelter. And so the counseling session was like pretty interesting at that point, because then you're looking at this family history of schizophrenia and other health conditions and the possibility of Klinefelter and stuff. So, yeah.
I
And
think we're
again,
still just discussing NIPT being a very common test, but I have received cases wherein the clinical indication is just a hypoplastic nasal bone, not even absent nasal bone, and it's preemie gravida non-consanguineous couple. There is absolutely no other history given to us at all. Just this is the entirety of the clinical indication we get, and the sample is sent for whole exome with CNV, a QFPCR, a FISH, a karyotyping, all four tests just together in one go, and all of them are negative. What do we look for?
yeah, in that case it becomes very difficult to explain the patients why they did go for the testing, why was the test suggested in first place, and after they have been economically also drained with all the testing, it is very difficult to make them understand. And then the when clinicians or anyone who has suggested them those tests that doesn't have any answers, they just navigate to the laboratory or the concerned person. They know, like, some other person might know some person who is connected to genetics. They'll just navigate the patient to them, and that cycle goes on. And here the patient will have no idea why what the testing was done, why what are the results and what are they supposed to expect now. With the hypoplastic nasal bone is still in the question if the fetus is going to be right, or like if there's something coming out or not, because ultrasonography if they, even if they do the ultrasonography again, there is a high possibility that the hypoplastic nasal bone which was seen earlier has resolved. It was just the angle of the fetus, they were not able to see the nasal bone.
Right.
So there again it becomes very difficult to make them understand that the finding that they were seeing earlier has now resolved. So again the question comes back and it stays in the loop until and unless the baby is not born and they don't observe and like observe the developmental milestones of the baby. So yeah, that's also one circle that goes on and on.
There's one more perspective, no, to absent nasal bone or hypoplastic nasal bone. So this is like a funny anecdote through like the first few years of my career as a genetic counselor. So I kept getting these referrals with just isolated hypoplastic nasal bone in during the NT scan. And the question of should we not do like a CVS. And then I would, at some point, I started asking them, have you looked at both of the parents and their ethnicities? So, you know, a lot of the times the couples would come in like with maybe one of the parent from Northeast, or even as a family trait, those who have like flattened nasal bridge or something that's not too obvious. You know, it is but obvious this is possibly the only thing that is going on. And so we yeah, we had like a running joke between the fetal med and me. And then eventually, you know, actually the fetal med, they would say, okay, call in the husband as well. I want to see both the couple together. And then they'll say, okay, this probably needs to go for genetic counseling. This possibly doesn't. We'll just do a further, the next scan, and we'll see what needs to be done. So, yeah.
Okay, I think we do need to end the session timely. But it was a very, very good session. And just before we end the session, one more thing, there is a PG genetic counseling student from AIMS Jodhpur with us today, and she wanted to get in touch with people who are from Delhi NCR to just get an understanding of industry experience that they have in Delhi NCR. So if anyone wants to reach out to her, her name is Tanu. They can reach out to her, or you can reach out to anyone who is present here. If you want to introduce yourself, you can.
Hi, my name is Tanu, and I'm currently pursuing PG diploma in genetic counseling from AIMS Jodhpur. And I have seen diverse cases like from pediatrics to cancer to antenatal, prenatal. I have seen multiple cases. But now, since it's like expected to be completed by the end of this month, so I don't know how to move forward in this profession. Like, since I don't know much, like where I can apply and how I can reach out to them, and what are different options, like what are different hospitals or labs who hire genetic counselors. So that is my main concern. If
Okay, so
anybody can
if
help me out in
anyone
that
wants to
thing.
reach out to her and help her, they can. And if
Possibly
you
Gangaram is a good place to start, Delhi side, because they have a genetics department as well. So
Can you please repeat that name?
this is Gangaram Hospital, SGRH.
Okay, okay. Thank you.
Okay, thank you everyone for joining in. And again, Akashi, it was a great session, great case histories and case scenarios. Thank you so much for teaching us. And we'll have you back again some week to teach us more.
Okay,
Thank you so much,
thank
Akashi. It was a
Thank you
great
so much,
session.
guys. Yes, it was. I tried my best, but I think next time if I come, I'll be more prepared. Yeah, the discussions are always great. So looking forward to join more sessions. So yeah, and it was nice to talk to you as well, Nimbi. The insights were very great.
Likewise, Akashi, and I hope I will be available. Like, this is one of the evenings that I was relatively free and I was able to join in. I've been meaning to attend one of these sessions for a while, but just never happened. So I'm glad I was able to join in today.
Yeah, it was good to see you and discuss the cases with you as well. Okay. Okay, guys. Thank you so much for the opportunity, and I look forward to attending more sessions of the club, and all the best to you. This is a very great initiative. And any help required from my end, I'm always available to you guys.
Yes. Thank you, Akashi. And thank you everyone for joining in. We hope to
Good
see
night,
you all
everyone. Have
again
a
for
great
next
weekend.
session.
We'll see you next week with some other session for sure.
Yes.